Welcome, Dr. Andrew Watson. Dr. Watson is a colorectal surgeon and vice president at University of Pittsburgh Medical Center, as well as a past president of the American Telemedicine Association. Welcome, Andrew.
Thank you, Steve. It's great to be here today.
Well, thanks for taking your time, and thanks in advance for sharing your formidable expertise on telemedicine. You've clearly been very involved with telemedicine, and perhaps you could start by telling us a little about the American Telemedicine Association, the size and composition and growth over the time with which you've been involved.
First, I want to thank you, Steve, and obviously all the regents and David Hoyt for all the work you've done at the College of Surgeons during this incredibly challenging time. It's truly unique, and it's been hard for us as surgeons, as we all know. The American Telemedicine Association has been around for just over 25 years, and it's the largest and most focused organization on telemedicine in the United States and actually North America. And we have about 5,000 to 7,000 members, and it's a composition of providers, nurses and doctors, allied health professionals, but it has many vendors as well. And it's important to bring the technology as well as the providers of telehealth and telemedicine together into the same space. And it's a good mixing. We're doing a lot of work right now on more of the long term about how you work with people who pay for healthcare, such as governments or regions. And we're also looking more about the value of telemedicine long term. But in the short term, there's been an incredible transition from face-to-face to virtual, which has been remarkable throughout the United States and elsewhere.
So what do you attribute the explosion? I mean, obviously the pandemic and the fact that we couldn't see patients face-to-face, but perhaps a better way to phrase that question is, why didn't it happen sooner? Why did it take a pandemic for people to realize that they could remotely connect with patients?
That's a good question. It's multifactorial. I'd say the number one reason is simply cultural change. It's hard for us. It's hard to break the most fundamental bond of healthcare, which is a face-to-face visit. And we've known for a while that the consumer electronics market was pushing us into the virtual world, but we never had a cause for that. And with COVID, that immediate need to be isolated forced the issue of now we can use smartphones, now we can use Skype, FaceTime, video. It just was the proverbial straw that broke the camel's back, and that's what it was. And there were also reimbursement challenges that in the United States have changed. There were also policy challenges, licensing challenges, and it's interesting how 15 years of not foot dragging, but just trying to understand this disappeared in 3 weeks, and all of a sudden telemedicine has effectively become the standard of care. I'm not saying it is, but in essence it is. It de facto is the standard of care right now.
So if we look at some of those challenges, there's the issue of confidentiality. And I know that prior to, largely from what thankfully from you, I've learned from you, there were limited platforms. So the platform had to be somehow approved to ensure appropriate level of confidentiality. There are technical issues for both providers and for receivers, if you will, in other words, for the patients, that the technical savvy of a teenager who needed to speak to their pediatrician might well be different than a nonagenarian who needs to speak with their geriatrician. So there are the technical hurdles there as well. And maybe we can just go over those and talk about what are the requirements for confidentiality first, if we just look at that one issue first.
It's a great question, and the safety of our patients and the security of information throughout the world is obviously of paramount importance after the quality of care that we provide. And one thing, and let me answer that question slightly indirectly, is that telemedicine has three very large areas right now. There's telemedicine that we grew up with, ICU care, stroke care, radiology, dermatology. There was a new form of telemedicine in 2015, which is live video visits right to smartphones. And the new version is remote monitoring, which came in about 2018. So going back to actually answering your question, if you look at security and privacy, teleradiology, pathology, dermatology, ophthalmology has been around for 20 years and it's worked. And so it's very rare you actually hear about security breaches in the telemedicine world. There are large platform providers and even smaller ones as well, but they are designed in a very secure fashion with unique identification, many securely linked to electronic health records or patient journals or other regional entities that house the information. So security actually has not been a major issue. And the reason why is we've become very good at security and privacy in the era of EHRs, and telemedicine has been able to use that expertise. So it's, they are doing very well in this realm of security and privacy, thankfully.
Good. And then that gets us to the issue of the individuals using it, both the providers and the patients. And I'd like to ask about the patients. How have the patients responded to being told, well, you can't come into the office, or perhaps reword that as you shouldn't come into the office for your own safety and the safety of the healthcare workers. But the good news is you can speak to your provider by video. How have patients responded?
The two most striking things about telemedicine are, number one, that patients get it. Our patients are being trained and educated by the consumer electronics market. In the United States, Google, Apple, Verizon, Samsung are training our patients how to use video, smartphones, text, chat. So the actual education of the patients has happened just through their everyday life. And so they've come to expect it. And I've had patients tell me, it's about time that you get caught up to the rest of the world. And they also respect the fact that there's an urgent healthcare need with this pandemic. And so when I see my patients, I've done about 530 or 40 consults. Not a lot, but I've got a number underneath me. And it's typically, the comments are very straightforward. I like this. I don't have to travel. Many times patients save time and money. It could be hours driving to a clinic, paying for childcare, taking a personal day off work, the expense of gas, petrol, tolls, parking, meals. It's very disruptive to come to a clinic. And so patients recognize that this is beneficial for them. They still get high quality care, but it's less expensive, that they don't have to pay for all the ancillary expenses that go into it. So by and large, they really like it. I've only had 2 patients out of 500 refuse. One wanted to go to a casino and gamble, and the other one actually did her subsequent follow-up with telemedicine.
You mentioned consults. Is there a role for using telehealth for consults? Many surgeons go to multiple different facilities or have huge campuses, and perhaps you're in the middle of a busy clinic. You won't get to a consult until 7 o'clock in the evening, but there's clearly some emergency. You can't find 30 minutes to walk across campus or an hour to drive somewhere else, but you can find 10 minutes to do a virtual consult. Is that appropriate?
I think it is. And I've done 185 telerounding episodes. Again, not a lot, but I have rounded on patients from LaGuardia Airport, Norway, Florida, New Jersey, my house. Patients want to see me. And so telerounding is the entree into consults. In consults per se, again, it's really how you build rapport for the patients. And if you can get there faster in a more efficacious fashion, and also with physician burnout, if it's easier for you, I think it's absolutely relevant. The biggest challenge with consults has to do with the examination. Many times we can use the electronic health records to get vital data, biochemical data, get imaging data, but the examination can be difficult. If you have a trained or even minimally experienced telepresenter, they can examine the patient and you can watch them. And they're also very effective peripherals that transmit lung sounds, heart tones. It can do imaging, very detailed imaging of lesions or wounds. And so it's a combination of watching somebody examine, using peripherals and using data. And we've been through this before as surgeons with the minimally invasive era. It's just different, but it works. And just like laparoscopic surgery, and Steve, you're an expert, it works for the vast majority of people. but it's not for everybody. There's no absolute here.
When we look at telehealth, we also think about rounding or individual patients. In some institutions and for some diseases, for example, bariatric surgery, there are group sessions where patients are counseled. Have those type of scenarios with a group counseling about bariatric surgery, for example, diabetes, I think is another one where these large education centers, and I think they're called shared appointments or shared patient visits. Have those been conducted through telehealth as well?
Absolutely. And this video itself represents an example of that. It's just 2 or 3 of us, but it could be 20 of us. The concept of having multi-party video conferencing has been around for a while, but in healthcare, behavioral health is really forcing this issue because group therapy and cognitive behavioral therapy is a critical adjunct to medications. And so the platforms that we're using now, Zoom, there's GoToMeeting, there are all these other ones. It's just a matter of creating a multi-site environment for people to interact and also chat. And so, yes, it works. It's very effective. And I think behavioral health is going to lead the field of medicine in this realm. And it's a very powerful tool that we can use as surgeons as well for, as you say, bariatric surgery or other support groups. You see it with our IBD Live Thursday morning webcast, and it's a very effective way to transmit data. It's just now it's just one person in a room versus 15 of us.
How about out of the United States? You're president of the board president of the American Telemedicine Association. Are there similar entities in other countries and or regions? And what's the penetration of telehealth once we leave the borders of the US for different parts of the world?
The telemedicine has its roots throughout the world. Australia has had a significant role in the development of telemedicine for behavioral health, ophthalmology, and other types of areas of telemedicine because of the distance and the separation in the outback in the middle. Europe has played a major role in telemedicine in monitoring with the whole system demonstrator project, areas in Norway and Tromsø, Norway, in the eHealth Directorate. We participated in the European Telemedicine Conference for many years, and there are other societies. It's just in the United States, we have a nucleating organization. It's a little bit different in other areas of the world, and it's mostly because I'm ignorant. But there is significant expertise in telemedicine throughout the world. In Europe being a prime example, Australia being another. China is an incredible user and very technologically savvy in terms of telemedicine, extraordinary capabilities. And India would be another country. But what we're seeing is that the United States built it under our policy and our regulatory framework, which is very conservative. Those countries have been very progressive, especially China, in using mobile data, advanced cell phone technology, more apps. And I think we have a lot to learn from other areas. We're all trying to do the right thing for our patients.
The last question I'd like to touch upon is education has been tremendously changed through this pandemic, that medical students are told not to come in and residents are being redeployed. Or how can we accommodate education where perhaps you have a medical student who's at home or sitting in a library or something, but not with the patient, and we're not with the patient because we're doing telehealth? Can we involve learners on video calls as we're doing here today? Is that being done so that the medical student can still participate in the educational process with the patient?
It's funny you should ask. In 20 minutes, I'm doing a course for the University of Pittsburgh Medical School for 4th-year students regarding telemedicine. And it's much like the image that you have on your LinkedIn profile of showing you doing a rectal case with everybody watching you. It's how do you take that model and distribute it through video, which can be done. And we've thought a long time about, do you have an open surgery being performed with cameras and somebody narrating it to a room of people so they can hear it? That's one way. But more importantly, if you look at medical students, graduate medical education, the education of nurses or APPs, how do you do that? And I was talking to someone inside UPMC recently, And there is a way using video. And it may come down to us effectively having a tablet in our pocket, which is our virtual education endpoint. And we simply put it on the table, clamp it to the bedstand, something small. You don't want it to be too large so it's overbearing for the patient. And the student will be able to see the entire room, and the patient will see a student's head and recognize there's a learner there, and the learner can interact and watch as well. I think there's a lot to come in this field, and there's a tremendous amount of expertise in surgery, certainly with you, your institution, the College of Surgeons, about how we rebuild education in the virtual world. Again, COVID has forced us to rethink how we do things, and we have been looking at this for a while, but now there's an urgent need. It can be done, and very well.
Well, thank you for your considerable expertise, for your time and your insights. Clearly very prescient, well ahead of the curve, as now many institutions seem to have shifted from a few visits here or there to the majority of the visits in telehealth. We all think it's here to stay. As long as the service is remunerated in the US, it certainly will be. And we appreciate your leadership in that direction. So thanks for your time this morning. And I look forward to seeing you in person, hopefully in the not too distant future. But in the meantime, on our various video conferences, stay healthy, stay well.
And same to you, Steve. And I think this relationship that we have, I consider you a friend and a colleague. And for those watching the video, we've never met. We've met using Twitter and using video conferencing. And I feel very comfortable calling him about cases or asking him advice. And I think the way that we've gotten to know each other is emblematic of the future of surgical education, because, you know, Steve's expertise is remarkable, and I always welcome the help. And I think this is what we can look to for telementoring and for teleeducation. But I thank you for what you do as a regent for the College of Surgeons and all that you and the college do. And appreciate being this discussion today. Thank you so much, Steve.
My pleasure. I appreciate your very kind words and our friendship.
Have a good day. Take care.